medical science is changing. For example, when we started talking about intermittent fasting, which is truly a method, it's literally the oldest dietary intervention known to humanity. It's been used for thousands of years. And we know that if you don't eat, nothing bad will happen. You'll burn some sugar, you'll burn some fat. That's the reason you have body fat, so that if you don't have anything to eat, you're gonna burn that fat. So nothing bad really happens. So intermittent fasting, for example, 5 years ago when I started talking about it and using it for patients as a therapeutic option, because we don't make anybody do it. We can't make anybody do anything. We give them the option to do it. Everybody thought it was the craziest, stupidest idea they'd ever heard. And just last month, I went to San Diego to give the keynote lecture for the Obesity Medicine Association, which is the largest association of obesity specialists in the United States. And there were hundreds and hundreds of doctors there wanting to know about how to use intermittent fasting so that they could also make their patients better. The problem is, I think that the doctors and the medical community in general is very slow to change. And that's really one of the reasons why I go to sort of popular books and social media, because this is a message that doesn't need to be delivered to a doctor to change the message. We want people to kind of be empowered. And the thing is that medical science, everybody thinks it moves very fast, is very, very slow. So you could have debates ongoing. If your blood sugar drops, then you don't need to take medications. And then if you continue to not eat, you'll lose weight. And then if you lose weight, your diabetes, your type 2 diabetes will go away. Again, I don't think anybody is going to argue with that. So the question is, why don't we just do that? And that's what we do. I'm not going to make my patient, who I know in 12 years will be on dialysis, I'm not going to make him wait 12 years assuming that I can actually get the funding for this. My duty to him or her is to take care of them right now to the best of my ability. So I do that. And we see cases every single day. So we have an intensive dietary management program. And every single day I come in, and just this morning, for example, I saw a lady, 15 years of type 2 diabetes, on 80 units of insulin, followed by a specialist, an endocrinologist. I took her from 80 units of insulin to 0, and her A1C is now 5.9%, which is classified, because she's on no medications and her A1C is below 6%. She's actually classified as a non-diabetic. So we took a severe type 2 diabetes, and in 4 months we moved her and she would be classified as a non-diabetic. This is a reversible disease, but I don't need to prove it to anybody. I need to treat people, and that's what I do. I mean, it would be great if somebody gave to me a couple $1 million to hire 5 or 10 researchers full time who can do a study, but that's not going to happen. And I don't see that as a very logical solution. We can do both at the same time. So when you take the message out sort of directly to the people on the front lines, that is the doctors who want to be there, the patients who want to be there, they want to know, because something like fasting, something like low carbohydrate diets, it's an option. I'm not saying that everybody in the world must do it. I'm saying you can give it a try. It's okay. If you do well, great. If you don't do well, then don't do it. But at least you have the option. It's like a tool in your toolbox. It's better to have that there rather than saying, oh, you must never do this. It's ridiculous, really, to give that sort of, to take away those choices from patients when they should really, be empowered to make decisions for themselves.